And we will start with Dr. Andrew Bostom.
Hey, there you go.
Do I need this? Can you hear me without the microphone?
You're good. One second. We'll get a second. There is the photo.
Yeah, that's right. I wanted to start talking anyway. Can everyone hear me without
It's better with the mic. Better for recording.
There you go.
Hello? Got it?
Perfect.
All right.
You're perfect, Andy.
So I am very, very humbled by what I've heard for the last several hours. And actually, it's a shame. I see Ms. Comella is still here, but Ms. Goulet, if I have that right, is not. She was the deputy COVID.
I'm right here.
Oh, you are here.
I just needed water.
Oh, that's good. I'm glad you got water. Because actually, I'm very impressed with the knowledge base of the audience. I think as far as the Rhode people here, I hope this basically serves as continuing medical education for you. Because I didn't see any of these data discussed by you in public, certainly, and maybe not in private either. We have some APA requests in to see about that. But what I did see is very reminiscent of Soviet pseudoscience called Lysenkoism. Trofim Lysenko believed that, Ellen, you can switch to the next slide. Trofim Lysenko believed that acquired traits are inherited. He claimed that heredity can be changed by educating plants and denied the existence of genes. And he was supported by Stalin and the Communist Party elites. And one of the consequences of this pseudoscience was that real scientists wound up in the Gulag, and some of whom were assassinated. And it set back Soviet science. And we saw a lot of that same sort of pseudoscience during the pandemic. Next slide, Ellen. I want to walk you back through what happened. How did we get into this situation? Lockdowns, mask mandates, just various other draconian measures. You can still watch this on C-SPAN if you wish. On April 16th, 2020, there was a live presser that Governor Raimondo gave, and you can make out Dr. Scott being at her side. And this was the release of models done by Rhode and Brown University. And I'll show you a picture. I wish we had a bigger screen, but we don't. But you can hear from what Governor Raimondo is saying. She's ecstatic about these models that are being put out, again, April 16th. And she'll tell you about a blue line you could think of as our best guess, and then there's a red line. And maybe you'll be able to make that out, but I'll give you the numbers if you can. Next line, Ellen. Okay, so you might be able to see that huge peak, the red line there, and then below that is the blue line. And then I did a little graphic on the other side. You can see that orange line shooting all the way up into the heavens. Those are all model data. The real data are along the baseline. And so what we have here is absolutely hysterical models in pretty much real time. These are not models that were put forth in January or February to predict what was going to happen at the end of April, the beginning of May. These were 2-week models, 2 weeks later. And what they predicted was that on April 27th, in the less compliant situation, where people were not adhering to the draconian restrictions, there would be 4,300 persons in the hospital because of COVID. Now realize we only have about 2,200 bed capacity for the state. So they would have doubled that capacity and obviously would have had to go into field hospitals. On the 27th, the actual number of people hospitalized was 356. In the good compliance model, there were supposed to be on May 3rd, 2,250 patients hospitalized because of COVID. And in actuality, there were 350. And where was the peak? the peak was neither at 4,300 nor 2,250. It was the peak, the actual peak was 373 on April 28th during this first wave. Next slide, please. In retrospect, we can now go back and compare the pre-pandemic hospitalizations, actual hospitalizations, not these hysterical and ridiculous models, by the way, for which there was never an explanation, let alone a mea culpa, in real time. We shouldn't be talking about these models 4 years later. We should have been talking about them in May of 2020. Why were they 6 to 12-fold off in real time? And so all I'm showing here is that if you look at the largest health provider in the state, which is Lifespan, if you look at the pre-pandemic years of 2018 and 2019 and compare those to the first 2 years of 2020 and 21, actual hospitalizations were almost 10% lower. Actual hospitalizations were 10% lower. And in fact, as we presented during Southwell versus McKee, right before the hearings began, towards the end of August, the second largest provider in the state, Care New England, had a conference call, because they're public, they have to have these public conference calls. They had a campaign to bring patients back into the hospital. Okay, so there was not a crisis vis-a-vis beds. Next slide, please. Well, one country, and probably the only country in the so-called developed world that handled the pandemic appropriately was Sweden. Sweden never locked down, they never imposed mask mandates, and they kept in-class primary school education, schools open throughout. Their national demographer, who handles the mortality statistics, gave a presentation on Swedish national television. And I apologize, it's hard to make out here, but the major points he's showing are the horrific 1918 pandemic, which was a serious pandemic, orders of magnitude worse than COVID. And then you see also World War II, and you see 2 flu pandemics in 1968 and in 1957 before that. And then you see coronavirus all the way towards the end. And what Dr. Hemstrom points out is that at worst, we are back to mortality of 2012. The excess mortality was the same as it was a decade before COVID, and it paled in comparison to what happened in the 1918 flu pandemic. Next slide, please. Look, we have simple metrics. We have simple metrics for death in relation to infectious diseases. We have something called the infection fatality rate. And these are the best data that have been pooled by Ioannidis' group at Stanford University. Ioannidis is the most published epidemiologist in the world. And very serious methodology was applied to world data that were pooled into Stanford. And what we can see here is that this was an extraordinarily age-stratified disease, that all the serious risk was conferred in people over 70 years of age. Conversely, that means that 94% of the world's population experienced SARS-CoV-2 as perhaps a pandemic flu or even a bad seasonal influenza, and that those people should not have been locked down, and they should have been allowed to circulate and work. And by the time you get down to children, it is an extraordinarily mild disease, mercifully. And we're talking about, even at its worst, maybe 1 death per 335,000 infections. And by the time we get to Omicron, it's maybe 1 death for over 1 million infections. Next slide, please. And this bears itself out in U.S. data. These are over 500,000 COVID hospitalizations. And just very basically, you can see that 2/3 of them are 2/3 of those who died are in people with about 6 chronic comorbidities. Those are not children going to school, and that more than 3/4 of them are in people that were above 65 years old. Again, very age-stratified disease. Next slide, please. What about here in Rhode Island? 78% of the deaths occurred among those greater than 70. 55% of the deaths occurred in those among 80, which is actually above the state's average life expectancy at birth of 79.8. 53% of deaths occurred in nursing homes or elder-assisted living facility residents, and no deaths, as we've heard here from these informed people, no deaths occurred in those under 18 during the period of the pandemic. And in fact, if you look at CDC data, there were 269 non-COVID pediatric deaths from the beginning of 2020 to about April 2022. So this was inconsequential in Rhode Island children. And in fact, this is occurring. We also have CDC data, which indicates that using seroprevalence data, using antibody testing in representative samples of Rhode Island children, the entire state's population of children was infected. So by extrapolation. So with the entire state's population of children at some point in the pandemic being infected, there wasn't a single death. And by the way, there were 3 pediatric deaths in about one flu season with the H1N1 swine flu, 2009 to 10. And I would also, well, Greg will elaborate on this. Dr. McDonald, late of the Department of Health, actually perjured himself on the issue of COVID-19 deaths during Southwell versus McKee. Next slide, please. So what about masking? Well, the CDC was actually pretty clear. As late as February 27th, 2020, they did not recommend masking. And as I will show you, absolutely nothing happened that should have changed that opinion, that recommendation, on the basis of what's gold standard evidence, i.e. randomized controlled trials. Next slide, please. Well, we've known that masking was a feckless, pointless thing to do for over 100 years. This was a very honest mea culpa that I picked out of the American Journal of Public Health. It was written by Dr. Kellogg, who was an infectious disease expert and executive officer of the California State Board of Health. So he was reflecting back on what had happened during 1918. And it was an honest mea culpa, something that we would like to hear from Rhode, for example. And what he said was, the failure of the mask was a source of disappointment. For the first experiment in San Francisco was watched with interest, with the expectation that if it proved feasible to enforce the regulation, the desired result would be achieved. The reverse proved true. The masks, contrary to expectation, were worn cheerfully and universally, and also contrary to expectation of what should follow under such circumstances, no effect on the epidemic curve was to be seen. Something was plainly wrong with our hypotheses. Wouldn't you all like to hear that? Okay, next slide, please. This is a very simple graphic. Again, it's from Rhode data, just looking at all the mask mandates and re-ups of the mask mandates, and they bear absolutely no relationship to the infection curve. In fact, you see the huge spike occurring when, according to a marketing survey that was done across the country, but including Rhode Island, at the point at which Rhode Island was the most mask compliant of all 50 states, that's right before we see this huge uptick in infections. Next slide, please. So what kind of data should the Department of Health have relied upon, which it clearly ignored, rejected? I don't know why. Again, it's the subject of APRA requests. Well, we've known for 60, 70 years that the gold standard for looking at therapeutics and interventions is a randomized controlled trial. Campbell and Stanley discussed this in terms of agricultural research back in 1963, and re-upping this idea as recently as 2008 was a paper by an evidence-based group out of Canada, Guyette et al. And the idea is that if you're going to engage in drug treatment, surgical treatment, or something as simple as a mask, and let alone mandating a mask, you have to have gold standard randomized controlled trial evidence. And in fact, when you have it, when it's consistent, that say, for example, randomized controlled trials actually showed that masking worked, at that point, you would make it a recommendation, not a mandate. As I will show you, we didn't come close to that. Next slide, please. So what was known in terms of randomized controlled trial data at the outset, at the very outset of the COVID pandemic? This is just one example of a meta-analysis, a pooled analysis of randomized controlled trials of masking in the community for the prevention of influenza. All the individual studies are negative, and then sometimes, because there can be small trends in these individual studies, they pool the data and see if, well, maybe now that we have more numbers, more statistical power, we can show a small trend. The meta-analysis was negative, and this involved about 12,000 persons. All these data were available before COVID. And in fact, that's probably why the CDC initially recommended against mask mandates and masking. And in fact, influenza and COVID behave exactly the same. They're almost exactly the same particle size. Next slide, please. And this is just to validate that there was one large study that was actually published during the pandemic, reiterating in influenza patients. These were amongst Hajj pilgrims. So the other pooled data was about 12,000. This was another 6,000. And again, the same thing in one study of Hajj pilgrims actually showed that masks had no benefit in terms of preventing primarily influenza, but other respiratory viruses. And in fact, there was some small suggestion that didn't reach statistical significance that they might actually increase the rates of infection. Next slide, please. I'm back to the CDC recommendation from right as the pandemic was breaking. And by FOIA request, we now know from Dr. Fauci's emails that he was very much aware of the negative randomized controlled trial data from influenza, and in fact had gotten a pre-publication accepted version of that meta-analysis from flu that I showed you, which actually was published in one of the CDC House organ journals. Next slide, please. Now, for many years, we've relied upon something called the Cochrane database. What Cochrane does is provide medical review syntheses. Now, if it's an area where it's a common clinical concern, surgical interventions, medical interventions, pharmaceutical interventions, and actually masking too, they will rely upon randomized controlled trial data. If it's some esoteric condition where it's been difficult to study with randomized controlled trials, they will resort to looking at observational studies. So Cochrane has been reviewing masking for well before COVID. As a matter of fact, they started doing a synthetic literature publications in the early 2000s. They came out with a meta-analysis, a pooled analysis right before COVID broke. All of these were negative. Again, these were just randomized controlled trials. Does community masking prevent respiratory virus infections? But then they actually came out finally in 2023, at the beginning of 2023, and they updated to review the literature in COVID as well. And they found that for prevention of COVID-like illness or prevention of laboratory-confirmed infections, the masks were completely ineffective. I can tell you now that there are 2 additional studies since the negative Cochrane review was published that have come out and have confirmed the same thing, and now they've moved into showing that N95s are no more effective than surgical masks. The Cochrane reviews that I mentioned before were comparing medical surgical masks to no masks. So if A equals B and B equals C, then A equals C. They all don't work. And we just had the largest study ever conducted that actually involved children. And there's a very interesting history to this study. This was done in West Africa, in Guinea-Bissau. It's a 40,000 person study. It actually included 10,000 children between the ages of 10 and 18. And none of the subgroups benefited from masking. There was actually even a suggestion of increased risk in the masking groups. And during Southwell versus McKee, as the plaintiffs remember well, and certainly Greg Piccirilli remembers well, Greg raised that study. It was actually completed but unpublished at the time during the court hearing. He mentioned the study to Dr. McDonald, and Dr. McDonald told Greg under oath that it was unethical to do the study. In other words, just mask the children because we know it works. It's unethical to do the study. Well, you know, thank God the University of South Denmark and one of the outstanding infectious disease epidemiologists in the world, Christine Stabel-Ben, got a grant and completed the study, and it's absolutely negative, and we have it in our body of negative literature, very consistent. One of the things that I found, this is from 2019. Next slide, please. This was very disturbing to me. I am very upset that I you know, it was published in a not a high impact journal, but this was actually a study done and published in 2019. It was done by Brown and Rhode investigators, and they published a peer-reviewed study in a journal called Medical Care, and they actually used and praised effusively the Cochrane reviews as a tool for teaching, quote, expert guidance to community partners in evidence synthesis. And if you've seen some of the discussions by CDC, by Rhode people, when the Cochrane review on masking came out in 2023, it was all negative commentary and deriding it. This is beyond hypocrisy to have actually published this study only less than 6 months before the pandemic came out, you know, before the pandemic was really evident, and a short time later disavow the Cochrane reviews because it didn't give the answer that they wanted. That's the only explanation for it, and it's grotesque hypocrisy. Well, next slide, please, Ellen. So what did Rhode rely upon in the end? What did they rely upon? We saw this in court. They ignored the gold standard evidence, utterly ignored the gold standard negative evidence, which would have told you mask mandates are useless and you don't mandate something that's useless. That's unethical. So what did they rely upon? You heard Rich talk about the PIMA study. Actually, if you look between 2019 and 2023, there was just a paper published last month in the American Journal of Medicine, reviewed all the studies between 2019 and 2023 in morbidity and mortality weekly reports, which is the CDC specific house organ. It is a non-peer-reviewed journal. I don't understand why people in Rhode didn't understand that, but we presented it in court, and they protested. They're wrong. It's not peer-reviewed. It's only reviewed internally within CDC. That is not outside peer review. Regardless, 77 masking studies, none of which was a randomized controlled trial. And I just want to read you from this published paper just last month in the American Journal of Medicine. We found that while less than 20% of MMWR studies pertaining to masks generated any statistical evidence of mask effectiveness, and no randomized controlled investigations were published, more than 75% of the publications arrived at a favorable conclusion about using masks, and 70% of studies testing masks used causal language. Similarly, language about the study's implications, including the importance of masking, was used in multiple publications despite lack of supporting evidence. This was the entire flimsy, ridiculous, counterfactual body of evidence that Rhode used to justify mask mandates. But as the late Billy Mays would say, but there's more. As they pointed out, a number of studies were particularly influential in shaping policy recommendations around masking in public and schools, were not even among the studies that attempted to properly evaluate masks, as they had no control group or comparative time period. These studies included the investigation of Missouri hairdressers, which came up in the trial, the Georgia overnight camp outbreak investigation, and the Marin County, California school investigation. Next slide, please. So my colleague Michelle Cortella, who's a pediatrician in the state, was going to talk about negative effects of masking, and she couldn't be here, so I'll run through it very quickly. And again, you all know that Judge Lanphier gave his ruling, which was a little oddly worded. He said that the masking caused some irreparable harm. Okay, So we know from the SARS-CoV-1 pandemic and the heavy use of masking in Asia that there was a report in 2003 that because of vast discomfort and distraction, it was causing social isolation in children, and that was for a very brief period of time. That was only a couple of months of masking. Fast forward to 2019, there was a randomized controlled crossover study of N95 masking in children that found within 5 minutes, masking significantly raised blood CO2 concentrations versus a controlled 5-minute period when unmasked. And then in terms of some of the things, we heard some very interesting discussion this morning by people with teaching and clinical psychology backgrounds. This was a controlled study that would confirm some of what they're reporting. This was a study of 72 children aged 6 to 14 years old, and they applied this instrument called the Cambridge Face Memory Test, which is a validated measure of face perception performance. And what they found was that substantial quantitative and qualitative alterations in the processing of masked faces in school-aged children as a result of masking, which could have significant effects on children's social interactions with their peers and their ability to form relationships with educators. And I think we've seen facts on the ground bear that out. In terms of educational measures, we've got enough data now to show that the pandemic response was a disaster, and part and parcel of that was masking. We've seen test scores both here in Rhode Island and across the United States significantly decline during the pandemic, and I don't think that needs to be reiterated any further. What I would like to show in contrast, next slide please. Yeah, sorry. The opposite. Sweden, again, through at least age 16, open schools, face-to-face education, no masking, no negative consequences in terms of educating school children. No COVID-19 related learning loss in reading in Swedish primary school students. The proportion of students with weak reading skills did not increase during the pandemic, and students from disadvantaged socioeconomic backgrounds were not especially affected. And contra the ridiculous stereotype, Sweden is no longer lily white Nordic country. It has had an amnesty policy for asylum for 30 plus years now. It has a very large Middle Eastern and African minority population, and they did not experience declines in their educational measures either. Next slide, please. So masking just fits into a larger context of this Lysenkoism that was imposed upon us in plain English. And we need to return to much more intelligent and thoughtful and experiential wisdom. And the late Donald Henderson was for many years dean of the Johns Hopkins School of Public Health. He spearheaded the campaign to eradicate a true scourge, smallpox. I mean, smallpox had a 20 to 60% fatality persisting at least at 15 to 30% into the last century. That was a real scourge. That was not this flu-like experience that we had with COVID. Perhaps that sobered him up to the idea about how you would plan for influenza outbreaks, even pandemic influenza outbreaks. And he was against every single thing that we did during the pandemic. Quarantining the well, mask mandates, closing schools other than for maybe a week or two. Every single thing that we did, he was opposed to, and because of the societal disruption. Next slide, please. What he said was, and I think it happened in front of our eyes, he said a manageable epidemic could move toward catastrophe. And so this is the type of tried and true wisdom we have to get back to. And my final slide. This is not a position of compromise, okay? We're supposed to, the least we should expect from the Department of Health is that they abide by actual evidence-based medicine. Period. End of discussion, no compromise. So with the permission of the plaintiffs, I put simple language onto it. There will be no regulation requiring masking in schools for the alleged prevention of respiratory viral infections until evidence of both their effectiveness and lack of harm has been demonstrated convincingly by multiple, rigorous, randomized controlled trials in school-aged children published in peer-reviewed journals. And that's got to be the bottom line. The rest is bullshit, as they say. Okay? Thank you very much.